Ma'am, 2 minutes to go live. If you can please make your presentation in full screen mode. One minute to go live, ma'am. In the first slide that I can see there's nothing as such written on it.
I'll click and it will come.
Oh, okay. It's sharp 3:30, ma'am. So with all your due permission, can we begin?
Yes, please.
Good afternoon, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. Ma'am needs no introduction, but it is my pleasure and honor to introduce her at our platform. She is none other than Colonel Dr. Bandana Sodhi, ma'am. Ma'am is MD, Obstetrics and Gynecology, DNB in Obstetrics and Gynecology, infertility specialist, and consultant at Fortis La Femme Greater Kailash. With the help of ma'am, we'll be taking a close look on today's topic, which is abnormal uterine bleeding. Before moving on to today's session, let us have a brief look on what the topic says. The term abnormal uterine bleeding refers to a wide range of anomalies in the menstrual cycle, including variations in flow volume, length, and frequency that don't occur during pregnancy. Up to 1/3 of women will experience abnormal uterine bleeding at some point in their lives. The perimenopausal and menstrual cycles are when these irregularities most frequently occur. We'll be knowing more about the topic with the help of ma'am and with her precious talk that she's going to conduct. Now, I would like to welcome ma'am at our forum, and without any further delay, I would like to hand over the session to her for her talk to begin. Ma'am, over to you.
Thank you, Batul. Thank you for such a lovely introduction. And good afternoon, everybody. Today, I'm here again with all of you to talk about a topic called abnormal uterine bleeding, right? This is a very vast topic, and to cover it in half an hour is like just giving you a bird's eye view of what all things we expect, what all things we should be aware of, and how we should proceed in cases with medical and surgical therapy. So it's a very, very big topic. If we start talking about it, it'll take at least an hour or two to talk about it in detail. As she has already introduced me, I am a senior consultant in obstetrics and gynecology and an advanced gynae laparoscopic surgeon practicing in Delhi. And I'm an ex-army officer, having worked as a faculty in FMC and Army Hospital Research and Referral. Moving on to today's topic. First, we need to know what all things we're going to be talking about today. We'll talk about some definitions, baseline etiologies, how to evaluate a patient with abnormal uterine bleeding, management, including both medical and surgical. For knowing the abnormal, we need to know what is normal. And what is the abnormality that happens is that there is change in frequency, in duration, and the amount of menstrual bleeding, which labels it as an abnormal uterine bleeding. So as I said earlier, to know what is abnormal, we need to know what is normal. So in a normal menstrual cycle, what we have is, we have a cycle which occurs every 21 to 28 days, lasts for 7 days. The mean duration is about 4 days. Anything more than 7 days is abnormal. The average blood loss during menstruation is about 80 ml. This is normal. Second thing is, we need to know what is menorrhagia. In menorrhagia means, these are different terminologies I shall be using now to explain what the abnormal uterine bleeding can consist of. First is menorrhagia. It is a prolonged bleeding. Number one. Number two, when the flow is more than 7 days or the flow is more than 80 ml in the entire duration. And this keeps occurring at regular intervals. That means not just one episode, but happening frequently. Then it occurs in 9 to 14% of healthy women and most common gynecological disorder of reproductive age group. In fact, menorrhagia is also seen in puberty, where it is called a puberty menorrhagia. Metrorrhagia. Metrorrhagia means uterine bleeding occurring at irregular but frequent intervals, or intermenstrual bleeding. That is what is metrorrhagia. That means occurring in between cycles at irregular intervals. Then is menometrorrhagia. That means frequent bleeding and prolonged bleeding and excessive bleeding occurring at irregular intervals. Next is oligomenorrhea. Oligomenorrhea means reduction in the frequency of the menses. That means cycles occurring beyond 35 days up to 6 months also are referred to as oligomenoric cycles. What is secondary amenorrhea? Secondary amenorrhea means there are no periods in a normally menstruating lady when there are no periods for more than 3 to 6 months. That is secondary amenorrhea. And there's a terminology called primary amenorrhea, which means that there is no onset of periods at all. So how do we define that? That means there are no periods in girls by the age of 13 with no associated secondary sexual characters. However, if there are no periods by the age of 15 associated with secondary sexual characteristics, this is also labeled as primary amenorrhea. So both are two different things because the underlying causes are different and the evaluation is different. These are just basic terminologies. Menarche means the age of onset of periods, and on an average it is about 12 years, 10 to 12 years. Now the age of menarche has come down to 10 because of better nutritional status of girls. Then menopause. Menopause means cessation of periods. That means when the periods do not occur for a gap of complete 12 months, that is labeled as menopause. The average age of menopause the world over is about 52 years. That means by the age of 52, a lady should attain menopause. This means that over a period of 30 years, every woman undergoes ovulatory cycles. Now we come on to the reasons behind the abnormal uterine bleeding. Why should it happen? There has to be some underlying pathologies behind it. They can be systemic or they can be local. That means they can be associated with the system of the human body, and local could be associated with abnormalities in the reproductive tract. Coming to the systemic etiologies, there can be coagulation defects. That means there is any coagulation defects in the body, like in ITP. ITP is idiopathic thrombocytopenia. Von Willebrand's disease. Von Willebrand's disease, these are all inherent problems which happen by the genetic mechanism which is passed on to the individual. Von Willebrand's disease is the most common inherited bleeding disorder, and it has a frequency of 1 in 800 to 1000. So when we talk of systemic etiologies, wherever the coagulopathies are there, we need a routine screening for coagulation defects. And this should be reserved for young patients who have heavy bleeding with onset of menstruation. I'm putting all these inputs in so that the mind starts thinking of these things. Second is we come on to hypothyroidism. Hypothyroidism is also associated with menorrhagia or metrorrhagia. So if there is no other underlying pathology which is found, one has to evaluate for coagulopathies, for von Willebrand's factor deficiencies, and for hypothyroidism also. The common causes of AUB, premenarche. Sometimes a young girl is got with abnormal bleeding from the vagina. Young girl means pre-onset of periods, premenarche. The commonest cause here is a foreign body in the vagina. Children, while playing, have sometimes done a small thing like put a foreign body into the vagina, like a marble or a piece of thread. I have myself seen about 2-3 girls who have little pieces hanging from the vaginal end, which they have done playfully. And this can cause an abnormal bleeding. In the reproductive age group, we have gestational events. That means the bleeding can be related to a pregnancy event, or it can be a postmenopausal event, or due to atrophy in the postmenopausal, or non-pregnancy reasons. So my teacher always used to say that if there is an abnormal uterine bleeding, one should always consider two things: pregnancy related problems and non-pregnancy related problems. So this will categorize things very easily, and you will be able to solve the problem at a very early stage. Gestational events could malignancies and benign lesions. So we've already spoken about the reproductive events. Then there are malignancies also, and there are benign lesions which can cause abnormal uterine bleeding. The benign lesions can be fibroids, they can be polyps, there can be cervical lesions, that means cervical erosion. Cervical lesions could be benign cervical lesions like hypertrophy at times with an infection of the cervix. Then foreign body, as I've already mentioned. Next is an infections. So here we see a uterus with some polyps here, polyp which is seen here and here. So these also cause abnormal uterine bleeding. Gestational events which can lead to an abnormal bleed can be abortion related, can be related to an ectopic pregnancy, or even gestational trophoblastic disease. Further, malignancies which cause abnormal uterine bleeding can be related to the entire genital tract, which could be endometrial cancers, ovarian and cervical cancers, commonest being endometrial and cervical cancers, which give rise to abnormal uterine bleeding. Now, this diagram, which I'm showing, very nicely conveys the different etiologies which we see. The above half deals with the PALM, P-A-L-M. That means polyps, adenomyosis, which is a condition where the endometriotic tissue sits within the uterine wall, leiomyomas or fibroids, and malignancy. Other ones is Coen, C-O-E-I-N, coagulopathies, ovulatory DUBs, endometrial problems where there is hormonal imbalance. Iatrogenic can be because of IUCDs or some medications, and otherwise non-classified, which includes cesarean defects. And this is a very common factor now, cesarean scar defects, which can cause menometrorrhagias, that means irregular menstrual bleedings. So if we remember this diagram, that is PALM, P-A-L-M, and C-O-E-I-N, COIN, which the FIGO has also given, we will never ever miss out any cause for an abnormal uterine bleeding. Now, knowing the etiologies, now we need to go on to the management. How do we manage a case of abnormal uterine bleeding? As we all know, the part of management includes a history, an examination, and then treatment. History, keeping all the points that I have told you in mind, one must take the history of the onset of periods, the age of menarche, the problem, what kind of bleeding she's having, whether it's menorrhagia, metrorrhagia, oligomenorrhea, classify it into the correct category, and then see if the lady needs a medical management or she needs a surgical management. Medical management, as I will be explaining now, is also various types, and so also surgical. Surgical would be conservative or a radical treatment. The aims of management. Number one, control the bleeding, prevent any recurrence of the bleeding, preserve fertility where it is desired, and correct any associated conditions, like if there is a coagulopathy, consult a hematologist along with it. If there is hypothyroidism, try and correct the hypothyroidism. So these are our aims of controlling an abnormal uterine bleeding. So the aims, if they are clear, the management will itself follow. What are the factors to be considered when we are treating or managing AUB? The factors are age of the patient, fertility status, whether it is required, not required, that means for the childbearing, if it is needed, desire for children, as I have explained, and there's a slight spelling mistake here, the report of the curettage that we do, whether it allows us to continue with a conservative management or not. Now, what are the management protocols that we have? First is supportive. Be kind, be reassuring to your patient that nothing will happen, everything will get sorted out with the correct methodologies. Hemotonics, to make sure that if her hemoglobin has fallen because of the menorrhagia, the patient is well built up on her hemoglobin by giving hemotonics. So supportive is this. Specific measures would be medical. Medical management would include hormonal, non-hormonal, and then is surgical management, which would include a DNC, which could be a therapeutic DNC. It includes endometrial ablation, and last but not the least, a hysterectomy. So these are the different methodologies we have when we are trying to manage a patient with abnormal uterine bleeding. Coming to the hormonal methods. Now, the hormonal methods will include medications, which are progesterons, estrogens, combination of estrogens and progesterones, androgens, GnRH analogs, and intrauterine devices which are medicated, and selective estrogen receptor modulators. So these are SERMs. I'll be covering each of them very, very briefly so that all of us know what we are doing. Hormonal therapy continued, progesterons. Now, the progesterons are the most common way of managing an abnormal uterine bleeding. The progesterons tend to control the bleeding and they deciduralize the tissue. So what do the progesterones do? They inhibit the augmentation of estrogen receptors. They suppress the estrogen-mediated transcription of growth factors, and they require to be given to stabilize the stromal changes. They have to be given for 21 days. It can't be just for 1 or 2 days, because the moment you stop after 1 or 2 days, the bleeding will start again. So to maintain the cyclicity, one has to give it for a certain period of time. Sometimes we have to give it towards the end of the cycle to stabilize, that is for 10 days. But normally if we start to stabilize from the 2nd or 3rd or 4th day of the period, then we prefer giving it for the whole cycle, that is 3 weeks, 21 days. So we stabilize the stromal changes, try and cause a deciduralization of the tissues using progesterones when we give it for a duration of 21 days. It reduces the blood loss by about 20 to 25%. The second is estrogen and progesterone combination. A low dose combination, they are low dose pills and normal dose pills. These are monophasic pills. These the common examples we use are like Overall, like Novolon, like Femilon. Femilon and others which are low dose pills, that means they have a lesser amount of estrogen, about 20 micrograms ethinyl estradiol, and the progesterone component. And the normal dose pills, they have 30 micrograms of ethinyl estradiol plus a progesterone. So the combination pill can be used also to control the bleeding. It reduces the blood loss by 40%. Now, the bleeding, it is also given over a period of 21 days. If the bleeding is excessive, we may even give a dose which is twice a day for 5 to 7 days, followed by 1 tablet a day for completion of 21 days. Each individual's requirement has to be customized. It is not a mathematics that one can say, okay, give this, give this, give this. No, you have to see the response of each individual. First, try and see what is the underlying cause. It is useful in patients who are also desiring additional contraception. Supposing a patient wants contraception also, then when we give a combined contraceptive pill, then it serves dual purpose for the patient. If we have to give only estrogens, now where are the conditions where we have to give only estrogen therapy? We have to give it for acute bleeding. If we have a girl who's bleeding acutely, a puberty menorrhagia that we call, that is after the onset of period, sometimes mothers get the child with severe bleeding which is not stopping. So in these cases, we may have to give conjugated estrogens as an intravenous route, 25 mg every 4 hours till the bleeding stops. And it can also be used for moderate bleeding, where it can be given in a tablet form, where conjugated estrogens are given in this dose. Even other estrogens where only estradiol is available can also be given. However, whenever we give estrogens, the latter half, the last 10 days, need to be covered with a progesterone. We do not give an unprotected estrogens. That means progesterones will be added towards the end of the cycle, like in a normal menstrual cycle. In a normal menstrual cycle, the first half has estrogen, the second half progesterones. So we try and modulate and try and copy a normal cycle where the initial bleeding is controlled by estrogens and the latter half is covered by progesterones along with it. Hormonal therapy being continued, we also have devices which are intrauterine devices, which can be inserted in the uterus, which secrete the progesterones. This is called LNG-IUS or Mirena. Mirena looks like a copper T, but it has basically got this has impregnation with the levonorgestrel LNG. So it releases a fixed amount daily. What does it do? It causes endometrial gland atrophy. It causes stromal desensitization, reduces the blood loss by 70 to 90%. It can be kept in the uterus for 5 years. It can also provide additional contraception because it's an intrauterine device itself. So these medicated devices also help in controlling the abnormal uterine bleeding. Coming to the next medical therapy is GnRH agonist therapy. GnRH are gonadotropin releasing hormone agonists, which will be which also help in controlling bleeding. They are for short-term relief. Normally pre-surgery, where we have to ablate the endometrium, we try and give GnRH agonists so that the lining becomes thin. It can also be given in patients where we can't give other medications which will have this thing in the body, where other effects may be there, like renal failure, blood dyscrasias, organ transplants, where other medications cannot be given. So this injection can easily be given. Next, we are continuing is with what are the types of GnRH agonists. These are available as buserelin, which is intranasal, goserelin, and leuprolin depots or leuprine acetate, which is given once in 21 days, right? This one. So this is the most commonly used, leupride depot, leuprolin depot. These are easily available. What are the side effects? They can cause a state of pseudomenopause. So they cause hot flushes, vaginal dryness, cause dyspareunia, acne, and bone weakness, osteoporosis. So one must always give an add-back calcium therapy whenever GnRH agonists are given. Desmopressin, I'll not talk about it because it's not commonly used. It is used basically to treat abnormal bleeding associated with von Willebrand's disease. Ormeloxifene. Now, ormeloxifene is a selective estrogen receptor modulator. That means SERMs that I was talking about. It has been earlier used widely. Presently, its use is a little restricted. What is it? How is it used? It is also called centroman, and it is used as 60 mg twice weekly for 3 months. Twice a week only dose, and thereafter once a week. So it is an antagonist to breast uterine tissue by anti-estrogen effects, and it has an agonist to bone and cardiovascular system, but it definitely thins out the lining. Since it modulates the estrogen receptors, it thins out the uterine lining and hence controls the abnormal bleeding. So having covered the hormones, now we come on to the non-hormonal therapy. I hope the inputs are not too much, because these things, however, have to be told to all of you, because you'll need to understand the various modalities of treatment. The non-hormonal therapy is very simple. We have antiprostaglandins. Then we have antifibrinolytics, and we have capillary stabilizing agents. 3 categories. Antiprostaglandins, antifibrinolytics, basically tranexamic acid, which we commonly use, can be given in a dose of 1 to 2 grams. 1 to 2 grams is the highest dose, not QID. This has been wrongly written. 1 to 2 grams can be given daily for 5 days. That means 500 mg 3 times a day can be given, maximum dose being 2 grams. This reduces the blood loss by about 50%. It counteracts the fibrinolytic system. Then we have prostaglandin synthetase inhibitors like mefenamic acid, which can be given 500 mg 3 times a day. Then it reduces the blood loss by about 20 to 50%. Capillary stabilizers are ethamsalate, which can be parenteral or oral, and diosmin. These are also commonly used, and it decreases the capillary fragility. Now we come on to the surgical interventions. The surgical interventions can be diagnostic, curettage, or therapeutic. Then there can be modalities of destroying the endometrium, where we destroy the basal layer of the endometrium and removal of the uterus. Right? These are the different surgical modalities available. Indications being where there is failure of medical therapy. Like if you have given 6 months of medical therapy and there is no improvement, or even after 1 or 2 months, the passage of clots is still there, then definitely surgical intervention is indicated. Then to correct any uterine pathology. Third is in combination with medical management, where we have ablation of the endometrium, or where there has been poor compliance as far as medical treatment is concerned. So the choice of surgery will depend upon the severity of the bleeding. It will depend upon the age of the patient, whether the patient needs further fertility or not. Uterine curettage can be, the different surgical options available are uterine curettage, endometrial ablation or resection, and hysterectomy. Curettage can be both diagnostic and therapeutic. If there is profuse bleeding, which is not going to stop with medications, so one has to do a therapeutic curettage where you remove the entire lining inside, and the same tissue has to be sent for diagnostic purposes so as to exclude the underlying cause, to exclude any malignancy. So it is indicated in acyclical bleeding when endometrial pathology is suspected, or wherever we want to exclude a malignancy, wherever we feel that if the age is more than 35, 40, and the chances of having a malignancy are higher, definitely an endometrial curettage is indicated. In fact, prior to a hysterectomy, please remember an endometrial curettage and a pap smear are mandatory requirements. No lady should undergo uterus removal without being subjected to an endometrial biopsy, because you may miss out on a malignancy, and later on, if there is a spread, she may need further therapy and further surgery again. What are the ablation therapies available? Ablation treatment is aimed at ablating the endometrial lining by using various sources of energy. These sources of energy can be first generation, which was used earlier, was TCRE, endometrial laser resection, roller ball ablation, and second generation is thermal balloons, microwave endometrial ablation, and hydrothermal ablators. So I'm just telling you so that you all are aware of all these things. The indications is where the patient is unfit for surgery, where she's not willing to get rid of her uterus. There are so many women in our country who just don't want to do a hysterectomy. They want anything and everything done except removal of the uterus. And if the patient is too obese, or as I said, she has anesthetic risks or other risks which she will face when she undergoes a surgery. The first generation ablation techniques, the difference between the two is that they are hysteroscopy dependent. They use an energy source, which is electrical, thermal, or laser. And we directly visualize through the hysteroscope. The next is, and this requires training. Every person can't do it. You need to be trained in these aspects to do a endometrial ablation. The second generation is non-hysteroscopy dependent. They are quicker, they are less skill is required, eliminates the use of distension media, and like balloon or hydrotherm. The TCRE, just wanted to mention what TCRE had done earlier was destruction of the basal layer of the endometrium. And this was first described in 1983. So since then, the ablative techniques have been used. The follow-up of these patients is at 6 months. This is what a balloon looks like in the uterine cavity, where this is a thermal balloon, where it is distended inside, it ablates the endometrial lining. This is how it is inflated, and this is how the thermal ablation is done. The contraindications being wherever there's a desire for pregnancy, or if there's an active genital tract infection, or if there's an anatomical abnormality or myometrial weakening where there is a previous cesarean or a myomectomy scar. So these are the contraindications for a local ablation. Now we come to hysterectomy. Hysterectomy is a permanent cure where the uterus is removed, and normally we remove the tubes also along. Seeing the age, we may not remove the ovaries. If she's beyond 47, 48, then removal of ovaries is suggested only after the patient's consent. And otherwise, the uterus is removed. The routes of hysterectomy are abdominal, vaginal, and laparoscopic. So the take-home points here, out of this entire talk, there are certain take-home points now. First is, in a young girl, menarche, adolescent patient, always think of a coagulation defect first. Always keep it in mind. Secondly, gestational events are the single most likely cause of abnormal uterine bleeding in a reproductive age group. So either she's pregnant, the lady, or she's not pregnant. So always in the reproductive age group, keep in mind that the gestational events can cause abnormal bleeding. 35 years or older with AUB, an endometrial biopsy is a must. If estrogen has to be given, screen for contraindications for estrogen, like family history of any breast cancers, they definitely need to be excluded. Levonorgestrel IUD is an excellent way to control AUB. This is a conservative method and it has very good results. Third, so these are the take-home points. So I've got you back home here. Most common cause of AUB in postmenopausal women is atrophy, but definitely malignancies have to be excluded by a hysteroscopy and a biopsy. Transvaginal screening is a very excellent tool for evaluation of postmenopausal bleeding, where the endometrial thickness is evaluated. If it is more than 4 mm, one has to ensure that a biopsy is taken, preferably hysteroscopic guided, as that is the standard of care world over. Women with recurrent postmenopausal bleeding definitely need a follow-up. Endometrial cancer risk factors are age, obesity, unopposed estrogen, and diabetes mellitus. So I've tried to cover everything in a very short time. I don't know how much all of you have understood. I hope something has been conveyed to you. Thank you very much. And if there are any questions, I would like to take them.
Thank you so much, ma'am, for your comprehensive talk and such wonderful insights that you have shared upon the topic. Thank you so much for your valuable insights. We have received a question and I would like to put it across to you. The question is, when is endometrial carcinoma included in the differential diagnosis of AUB and how is it ruled?
Endometrial cancer, if a lady who's perimenopausal is having abnormal bleeding in the form of menorrhagias or menometrorrhagias, definitely a biopsy is required. And as I said, the ideal way is to do a hysteroscopy and take a guided biopsy. That excludes, and a biopsy is the first thing that needs to be done to exclude an endometrial cancer.
Thank you so much, ma'am, for answering the question. I hope that all the viewers who were here, they would be definitely receiving the knowledge, wonderful knowledge that you have shared, and it would definitely going to help them in their daily clinical practices. So thank you so much, ma'am. Thank you for your valuable time. And with all your last comment, we can conclude the session here for today.
These are short talks. They are just insights into things and problems which we commonly face as doctors. So these talks are basically, this talk especially was given just to make sure that people who are getting patients, women with abnormal bleeding, do not shy away from evaluating them. Must keep your mind open and try and see how much you can help out maximally to the patient to benefit her. So I hope some things have been understood. If I've been unclear about a few things, pardon me, but it's a short time to cover such a big topic.
Thank you so much, ma'am. Thank you for your valuable time and thank you for your valuable comment. With all this, we are concluding the session here for today. Until next time.
Thank you. It's a pleasure.
Thank you, ma'am.